Welcome to the third lecture in the NYCDS Colloquium Series and to the Hofstra event series for National Public Health Week. Thank you so much for joining us. Melissa Randazzo from Adelphi will introduce the speakers in a second, but I just want to make a couple quick announcements. First, I want to plug an event that's on Thursday at 4 p.m. as part of National Public Health Week at Hofstra. The event is called The Scope of Practice of the SLP and Audiologist During the COVID-19 Pandemic. It'll be conducted by two faculty at Hofstra, Susan D. Metropolis and Wendy Silverman. I'll put the RSVP link in the chat in case anyone is interested. And the other thing is regarding CEUs, Max Freeman of St. John's will put the CEU form in the chat toward the end of the event. And with that, I'll turn it over to Melissa Randazzo from Adelphi, who will introduce the speakers.
Thank you, Scott. Hello, everyone. Welcome. We're so excited to have you all here today. I'm going to introduce the speakers. I'm going to just introduce our first speaker, and then we have two more speakers after that, so I'll introduce each of them before their respective talks. Our first speaker today is Dr. Ashwini Namasavaya Mcdonald. She is assistant professor and a speech-language pathologist at McMaster University in Hamilton, Canada. She is a prolific researcher in the area of swallowing. She studies the determinants and consequences of dysphagia in older adults. She was awarded the 2020 recipient of the American Speech Language Hearing Association's Award for Early Contributions in Research, and she was recently awarded an NIH grant to study COVID and swallowing. Thank you, Dr. Namasavaya Mcdonald. We are excited to hear your talk today.
Thanks so much for having me. I'm just going to share my screen here. Can everyone see that?
Yes.
Perfect. Great. So hi, everyone. Thank you so much, Dr. Randazzo, for inviting me to speak today. So I had the pleasure of working at Adelphi University for 2.5 years before moving back to Canada just before the pandemic hit. And I was just telling everyone I miss New York every single day. My research focuses on swallowing and swallowing disorders in older adults, as Dr. Randazzo suggested. And in spring 2020, I actually started working closely with Dr. Luis Riquelme, who is an associate professor at New York Medical College. And we basically developed recommendations for SLP practice in acute care with patients with COVID-19. And we're currently working on a follow-up paper to summarize available evidence that supports our recommendations. I have also helped to establish rehab guidelines for COVID-19 with my colleagues at McMaster, so alongside PTs and OTs. And I'm now collaborating on a project with Dr. Katrina Steele at Toronto Rehab Institute and Dr. Emily Plowman at the University of Florida, where we're trying to learn about the impact of COVID-19 on swallowing function. So I'm very interested in this topic, and I'm pleased to share some information with you today on the manifestation of dysphagia in patients with COVID-19. So here are my disclosures. So in order to, talk to you a little bit about dysphagia and COVID-19, I'm hoping to first, build up the story and tell you a little bit about COVID-19 symptomology, talk to you about dysphagia-related COVID-19 research, so mine and others, and then just briefly discuss possible treatment options, because I think that's the big question right now. So just a little disclaimer before we move forward, because there are thousands of publications on this topic, this presentation is not comprehensive. It can't be comprehensive in terms of research, but I've attempted to gather and summarize the most relevant research for you as of March 2021. So first, let's talk a little bit about symptomology. So the course of COVID-19 can be divided really into 3 stages. And the first early stage includes viral replication, and it's associated with this mild flu-like symptoms, such as fever, dry cough, and fatigue. And sometimes there are no signs or symptoms at all. So in this image, we see the most commonly reported symptoms of COVID-19 in this early stage. The second stage includes viral pneumonia and exacerbated inflammation of the lungs. And in this stage, patients tend to experience hypoxemia, which is a low concentration of oxygen in the blood, along with fever and dry cough. And the earliest signs of hypoxemia are confusion, restlessness, and shortness of breath. So shortness of breath is really key in relating things back to dysphagia. And then finally, in the third stage of COVID-19, there is this transition to a hyperinflammation state, and really low blood sugar is what we're seeing. So a recent systematic review looked at 148 articles that included over 24,000 patients total. So this review found that about 17% of hospitalized patients who were in the second and third stages of the virus required non-invasive mechanical ventilation. Now, this means that they needed oxygen via a face mask and didn't require an endotracheal airway. This review also found that 17% of patients required intensive care and 9% required invasive ventilation, meaning some sort of tube was inserted directly into the airway to deliver oxygen to the lungs. And if you think about that, that tube being inserted can also cause damage to the laryngeal mucosa, and which is directly involved in swallowing. So an important thing to keep in mind. So here we see a table from another recent study detailing the signs and symptoms of patients infected with COVID-19 during hospitalization. So this is really early data, and we now know that people also had loss of smell and taste, as well as blood coagulation leading to strokes in the most severe cases. If we bring our attention to the column outlining symptoms of severe cases, we see that similar to those mild stages, the most common symptoms are this fever and then the cough, so the dry cough. So as you can see, there's a whole host of different things that happen. And I think that's what's so challenging about addressing COVID, is that these patients are very complex. So we also know that many people suffer from ARDS, or acute respiratory distress syndrome, which is a life-threatening respiratory failure. And the severity of ARDS is classified into categories of mild, moderate, and severe, depending on the degree of hypoxemia. Now, patients with moderate to severe ARDS require invasive mechanical ventilation and generally have a pretty poor prognosis. Another review was able to incorporate data from individual studies for which data was available, and found that among hospitalized COVID-19 patients, approximately 1/3 develop ARDS. About a quarter required transfer to ICU, 16% received invasive mechanical ventilation, and unfortunately 16% died. For COVID-19 patients transferred to an ICU, about 2/3 received invasive mechanical ventilation, and about 75% had ARDS. The mortality rate of ICU COVID-19 patients was 40%, and 59% for those who received invasive mechanical ventilation. The mortality rate in COVID-19 associated with ARDS was 45%, and the incidence of ARDS among non-survivors of COVID-19 was 90%. So clearly this respiratory distress is a huge issue and an indicator of poor prognosis, as I suggested before. So another recent study looked at some of the more persistent symptoms of COVID-19 about 3.5 months post-hospitalization, and found that about 40% of people continued to suffer from dyspnea or shortness of breath. So that's 3.5 months out. And we had over 50% of people reporting fatigue. And about 1/3 of people also reported memory loss and trouble sleeping. So how do all of these symptoms impact dysphagia? Well, in the early stages of the disease, loss of taste and smell may indicate cranial nerve damage. So more specifically, loss of taste may indicate damage to cranial nerves 7, 9, and/or 10, which could ultimately influence both the oral and pharyngeal phases of swallowing. If someone is reporting difficulty breathing, we need to be on the lookout for impaired respiratory swallow coordination, which will increase the risk of aspiration during the swallow and aspiration pneumonia. And for those of you who may not be familiar with swallowing, just a quick reminder that we actually cease breathing. We have a period of swallow apnea in order to close the airway during the swallow. So in functional swallowing, we actually stop breathing for not very long, not even a second, to protect our airway. So we need a respiration and swallowing to be really nicely coordinated. So if it's not coordinated, we're basically keeping the airway open, perhaps during swallowing, which increases our risk of aspiration. So aspiration is material entering the airway and moving into the lungs, so below the vocal folds and into the lungs, increasing our risk of aspiration pneumonia. So that's pneumonia caused by this bacterial infection because a foreign material has entered the lungs. Another thing to consider is that a sore throat could lead to painful swallowing, which might in turn lead to people swallowing with less effort, leading to increased oral and pharyngeal residue, so material left behind in the swallowing tract post-swallow. Or they may be eating less because of this painful swallowing, which is a risk factor for malnutrition. And a lot of my work has suggested that dysphagia is a big contributor to malnutrition. Finally, invasive mechanical ventilation can impair airway protection if there is any damage to the laryngeal mucosa or vocal folds upon intubation or extubation. So I know this is confusing, but we're going to go through it row by row, and I'd like you to really consider some of the more general effects of COVID-19 on long-term outcomes. So first, we know that many patients are being treated with dexamethasone, which is a corticosteroid primarily used as an anti-inflammatory and for its immunosuppressant effects. So some things to be aware of if you have patients who are taking or have taken this drug is that it's associated with ICU-acquired weakness, which will increase risk of dysphagia. So ICU-acquired weakness is clinically detected weakness in critically ill patients in whom there is no plausible etiology other than the critical illness. Mechanical ventilation is also a risk factor for ICU-acquired weakness and is a barrier to mobilization. We know that this will increase risk of aspiration pneumonia in the presence of dysphagia and will increase fatigue. Many patients in the ICU are also being sedated, which leads to delirium and is another barrier to mobilization. Once again, increasing the risk of aspiration pneumonia, reducing cognition, and increasing risk of dysphagia. Proning is another treatment method found to be effective in patients suffering from COVID-19. So some hospitals are actually trialing awake proning, but we know if people are proned while sedated and paralyzed, they're going to experience a lot of atrophy and weakness, which will once again increase the risk of dysphagia. I think you can see the pattern here. Some patients are also given neuromuscular blockers to assist with acute respiratory distress syndrome, or that ARDS that I talked about before. And the main side effect of these is that we should be considering is really impaired cognition. Lastly, we really need to consider the impacts of the current visitation policies, or really lack thereof, for many of our patients right now. Because of the isolation and associated distress for both patients and their families, we're likely to see a lot of post-intensive care syndrome. This is made up of health problems that remain after critical illness, and they are present when the patient is in the ICU and may persist after the patient returns home. So many of these patients suffer from continued ICU-acquired weakness, impaired cognition, and post-traumatic stress disorder, which I don't think we're really thinking about right now. And they often have anxiety and depression, which might ultimately affect their motivation to participate in swallowing therapy or really any other type of therapy, and or their adherence to any recommendations we give. We also know that those who have less visitors are less likely to mobilize while in hospital, which increases risk of atrophy, dysphagia, and aspiration pneumonia in the presence of dysphagia. And then lastly, I didn't include it on this chart, but we know that people are also being given anticoagulants to prevent strokes, and then remdesivir, but these have fewer side effects and are unlikely to really directly affect SLP practice. And then I just want to bring your attention to this really seminal paper to help us think about the physiologic factors related to aspiration risk as laid out by Doctors Katrina Steele and Julie Cicero. So this is not specific to patients with COVID, but I think it's broadly applicable. And you'll notice that the last 3 points revolve around respiration, which we know will be impaired in patients with COVID-19, suggesting that they are once again at an increased risk for aspiration. So many patients are reporting chronic respiratory fatigue and difficulty breathing. So these are just some physiologic factors that we can keep in mind. So as we consider the effects of COVID-19 on long-term outcomes, you might have noticed that the reoccurring theme was that COVID-19 increases risk of dysphagia for a variety of reasons. And in turn, dysphagia can lead to increased risk of aspiration pneumonia, increased length of stay in hospital, increased risk of readmission to hospital, increased risk of malnutrition and dehydration, and increased risk of mortality. So therefore, it's extremely important that dysphagia is properly managed in patients with and recovering from COVID-19. So I'd now like to share some new information presented at the Dysphagia Research Society meeting in March that might help to understand how dysphagia manifests in patients with COVID-19. So this first study was conducted by Dr. Michael Puglia at the University of Wisconsin-Madison, and he looked at patients who entered the emergency department with COVID-19. He found that of the 134 patients enrolled in his study, 24, or about 18%, presented with dysphagia. And ultimately, he found that 1 in 6 patients presenting to the emergency department had dysphagia, but only 9 participated in a bedside assessment, and 16 participated in a video fluoroscopy assessment of swallowing. So that's an X-ray video assessment of swallowing, which is our gold standard assessment modality. And when controlling for several other factors, Dr. Puglia found that dysphagia is an significant independent risk factor for severe COVID-19. So that's really unique and the first time that's really been reported in the last year. The next study presented by Dr. Courtney Tipton looked at the makeup of COVID-19 patients diagnosed with new onset dysphagia with the aim of understanding rates, risk factors, and complications. So she enrolled 78 patients and found that patients waited on average 11 days before seeing an SLP, which may represent delays in care. She also found that about a quarter of patients resumed a normal diet upon discharge, meaning that most patients were actually discharged on a modified diet. So meaning they're drinking thickened liquids or maybe eating soft salads or puree, so not eating what you and I typically eat. She found that about 1/5 required a tube feeding at discharge. Although post-intubation dysphagia is thought to play a significant role in dysphagia associated with COVID-19, Dr. Tipton found that only 51% of patients enrolled in the study were intubated. And she found that patients with new onset dysphagia required significantly more consulting services and had a significantly longer length of stay than those who did not present with dysphagia. So that aligns well with the pre-pandemic data I presented before. And so together, these studies really show the importance of SLP involvement from the onset of a COVID diagnosis, especially if there's a pre-existing dysphagia. And management of dysphagia may help to reduce the severity of the symptoms associated with the virus, as well as length of stay and number of healthcare team members involved with patient care. So importantly, these studies suggest that patients with COVID-19 might require long-term rehabilitation for their swallowing difficulties. So that brings me to the NIH-funded study that I'm conducting with Dr. Katrina Steele, who is the principal investigator. So I'm co-PI, and we are trying to understand the prevalence and pathophysiology of dysphagia and really understand the impact of dysphagia on other health-related outcomes with the intent of informing rehabilitation targets. So we are currently enrolling any adult patients previously diagnosed with COVID and are assessing swallowing physiology and collecting a host of other information, including whether they've been vaccinated, if they were hospitalized due to complications associated with COVID, if they've required mechanical ventilation, information about pre-existing medical conditions, any reports of dyspnea, and we are measuring tongue strength and cough strength. So essentially what we want to do is understand how all of these factors do or do not contribute to dysphagia, and how this dysphagia is similar or different to swallowing difficulties that present in other patient populations. And we're hoping to really pinpoint targets for treatment, as I said before. So really, I'm sure you're wondering, what treatment can you do until we learn more about pathophysiology of swallowing in patients with COVID-19? So I'd like to end by just suggesting two forms of treatment. Based on what is currently known about respiratory fatigue in patients with COVID-19, which could result in impaired respiratory swallow coordination, which I talked about before, respiratory swallow training may be beneficial. So we have no available data on the use of this technique with COVID patients, but it's an intervention focused on optimally coordinating breathing and swallowing. So typically, we look for what we call an exhale, swallow, exhale pattern. So we expect people to breathe in, breathe out, swallow, and breathe out again. And that really helps to decrease the risk of airway penetration and improve key components of swallowing impairment. So essentially, we're targeting poor laryngeal elevation. So the larynx needs to elevate to help protect the airway during swallowing, so poor laryngeal elevation would lead to poor airway protection and reduced pharyngeal clearance. So more residue in that swallowing tract. The thought is that swallowing during expiration facilitates movements required for laryngeal elevation to ensure airway protection and pharyngeal clearance. So if your breathing and swallowing is not coordinated, your airway may remain open during swallowing, increasing your risk of aspiration. And I want you to remember once again that breathing and swallowing must be coordinated to prevent aspiration, right? We want the airway to close, and we want breathing to cease for really a second or two until the bolus or the food or liquid moves through the pharynx and into the esophagus. So another treatment option is expiratory muscle strength training, and this is an intervention involving block practice of exhalation through a mouthpiece fitted with a one-way pressure valve, blocking the flow of air until the patient produces sufficient expiratory pressure. And with this intervention, we are targeting poor hyolaryngeal excursion for airway protection and upper esophageal sphincter opening. So that's the sphincter at the bottom of the pharynx that really is the gateway to the esophagus. And the theory is that if you breathe through this EMST device, you will activate the submental muscles that play a key role in facilitating hyolaryngeal excursion. So that's going to help elevate the larynx and close off that airway during swallowing. And I'd like to give a quick shout out to Danielle Braitz from NYU, who has done some really great research that's shown that high excursion is best assessed instrumentally and is not reliably assessed at the bedside. So really this tells us that impairment should be identified via video fluoroscopy before treatment options are explored. So those are two treatment options that may be useful for patients with COVID-19. But like I said, we don't have any data on that yet. So in summary, I hope this presentation has made clear that patients with COVID-19 are at high risk of acquiring dysphagia. Dysphagia increases risk of severe COVID-19. SLP should really be involved throughout the continuum of care. Therapy should consider how respiration is affecting swallowing. So working closely with your respiratory therapists or PTs doing any chest work. And we are still trying to understand the causes of dysphagia and the optimal treatment targets for patients recovering from COVID-19. So thank you so much for your attention. If you have any questions, I'm happy to answer them, or you can reach out directly.
Thank you so much, Dr. Namasavaya Mcdonald. That was very interesting and informative. We do have one question in the chat, and we have about 5 minutes. So if other people want to raise their hands or put a question in the chat, I'm going to go ahead and read out chat questions. Our first question is from Dr. Laura Koenig, one of our speakers for today. She says she'd like to understand more about why proning can be a particular risk for atrophy, and if this is about gravitational effects on the respiratory system, or if there is something more to it.
Sure, that's a great question. So it's actually a lot more simple than that. It's really the fact that they're not moving. So they're not moving, so that's going to lead to the atrophy. We actually have it, it's actually the help with breathing. So it's that's the whole purpose of why they're put face down, but it's the fact that they're not moving, and because they're sedated also. So that I alluded to at the beginning that some people are doing this awake proning, but because they're sedated, they're really not moving. So they're sedated for long periods of time. And then we're basically seeing in general, so pre-pandemic data has suggested that people lose muscle mass at a rate of 2 to 11% per day when they're sedated and prone like that. So that atrophy is a big concern. And actually, Dr. Sonia Melfenter from New York University does a lot of work on pharyngeal atrophy that I think in healthy participants that has really informed the swallowing world on the effects of atrophy on swallowing.
Do we have any more questions for Dr. Namasavaya Mcdonald before we move on to the next speaker? Okay, I don't see any hands going up and I don't see anything else in the chat. We will stay on for Q&A after all three speakers, so please stay tuned if any questions occur to you. I'm going to introduce our second speaker now. I am excited to introduce to you Dr. Barbara E Weinstein. She is professor and founding executive officer of the Health Sciences doctoral programs at the Graduate Center CUNY. She is also an adjunct professor of medicine at NYU Langone Medical Center. She received her PhD from Columbia University, and she is the author of both editions of the Geriatric Audiology. She has also received the Asha Lewis DiCarlo Award, and she is a 2016 recipient of the New York State Speech, Language, and Hearing Association Distinguished Clinical Achievement Award. We are very excited to hear about her research today about COVID, masks, and hearing. Dr. Weinstein, you are welcome to share your screen and start your presentation.
Great, thank you. Okay. Here we go again. Let's see. That's weird. So can you see is my screen visible? Is it visible?
Yes.
Yes.
Oh, great. Okay, thank you. So thank you very much. And I'm excited to share some data with you. I want disclosure. My financial arrangement is I'm a professor at CUNY and that my salary is paid through the Graduate Center. I wanted to continue to build on what Dr. Ashwini said in terms of building up to the story. But before I do that, let me just share why I ended up becoming interested in this area. I was in the hospital with my 93-year-old aunt on about March 7th before New York locked down. And what was most amazing was that the doctors and the healthcare providers were all wearing masks. And at the time, there were about 7 people in beds, and they were all older, and they had somebody with them. And the only thing, and you could only hear the doctor or the healthcare provider talking to the patient, and then the patient saying, "I can't understand you with your mask on," and then the family member answering. So fast forward to when we got on lockdown, I felt helpless as an audiologist. All these healthcare workers, everybody was making a difference, and I was not doing anything except sitting in my home and going outside and clapping every night. So I decided to do an experiment because I noticed that speech understanding was impacted by wearing masks. So I did publish one of the first articles on masking, the effect of masking on speech understanding, because I was just motivated to do something and I had a firsthand experience. So I wanted to first share a little bit of a virology primer. Dr. Ashwini talked about the progression in terms of the physiological symptoms. I just want to talk about the progression in terms of the viral load. And I'll quickly go through this just as a reminder. So as we know that COVID is unique in terms of the route of transmission is through small respiratory droplets. And they're expelled many ways. They're expelled through coughing, they're expelled through sneezing, and they're expelled through speaking. So phonation, sneezing, and coughing actually produce a higher level of particles than breathing. So speaking produces more droplets than coughing, and louder speech actually creates a larger quantity of droplets than softer speech. So again, singing creates even more. So when a person speaks, he releases nearly 200 viral particles per minute. So it would take 5 minutes of speaking face to face to receive a dose of particles large enough to infect others. And therefore, because of this, that we have some mitigation strategies which have been put into effect. And the mitigation strategies to stop the spread of COVID, as we all know, include wearing a mask and physical distancing, social distancing. And what's interesting is that these two mitigation strategies are the enemy of communication and the enemies of hearing, while of course they are critical to mitigating the spread of the disease. So in terms of communication, as we all know, as being communication specialists, and I remember taking a course in interpersonal communication when I first started in this field, and I didn't know that it was relevant, but it certainly is relevant. And we know that communication is a feedback loop. And in this feedback loop, the mitigation strategy masking impacts both the sender and the receiver. And what we also know about communication is that communication is 93% nonverbal. About 55% is body language, and we have a high proportion in terms of vocal tone and pitch of the voice. Much of this is masked through the vocal tone is impacted by the masking. Facial expressions are impacted, of course, in words. So body language takes on greater importance. So let's look at, so the consequences for communication can be deafening. It's conveying simple information is impacted, conveying empathy and reassurance impacted, speech is dampened, voice is distorted, and there's limited interpretation of the facial expressions. So what I would like to do is go through a little bit of the science of this and the studies that have been published. My publication was in April 2020, and since then there have been numerous publications, as Dr. Ashwini has suggested, in the area of dysphagia. So in terms of social distancing, as we know, pre-COVID, we were close to the speaker. In fact, we always advise hearing impaired people to always sit within 3 to 6 feet of the speaker. And now, of course, we have this physical distancing post-COVID. And what's interesting, some of you might remember this in your audiology class, which most of you in the audience decided to change to speech pathology, possibly because of some of these laws that we went over. And what happens is there's this inverse square law and audibility. And basically the bottom line is the further you are from the speaker, the greater the drop in the intensity of the signal. So sound diminishes by approximately 6 dB for each doubling of distance. And that's why we suggest that with hearing impaired people, you want to speak between 3 to 6 feet, but we can't do that with COVID. So this physical distancing creates a barrier right away. Social distancing makes the voices softer, as the further away from the speaker, the greater the drop in loudness. It's hard to see the speaker's face from a distance as well, so that's another issue as well. So there's a lot of mishearing what others are saying, making communication difficult, as we all experienced. So a little bit, and face masks is the next big mitigation strategy, and they're an ally when it comes to fighting the virus, but a challenge for persons with hearing loss. So what we know from facial expressions, as I suggested before, by covering up the lower part of the face, transmission of vocal tone is impacted, facial cues and cues from the mouth and lips for speech reading are missing, visibility of facial expressions hidden, and the face is hidden, so body language, as I suggested, takes on greater importance. So let's look at some of the acoustic impacts of face coverings. So as I suggested in beginning of April, I ended up being frustrated by being helpless, and a colleague in Israel had written to me about some product that he was producing, and I asked him if he could, in his lab, help me figure out the effects of masking on acoustics of speech. So he actually, he has a very big technology company audio simulators. So he said, sure, Barbara. So in 36 hours, we were able to get this study completed, written, and actually published. So, and here are the results. So what happens is, and at the time, we had different masks. We had no mask, of course, the simple mask, N95 and N95. And as you recall, in the beginning, in April, N95 masks, they were not available. We were not really permitted to wear N95 because that had to be for the hospital workers. And there were simple masks, and we didn't have as many mask options as we'll see later on. A number of different masks have come on the market since the beginning of April. So what we know from this study is that medical face masks essentially serve as a low-pass filter, attenuating your higher frequencies where most of the energy, as you recall, is important for understanding speech. The high frequency consonants are now rendered inaudible, and because of the masks, they're not visible on the lips. So communication accuracy is severely compromised. And there's a differential effect in terms of the different masks. And we'll see more research on this in other studies that were published later than this. And what we see here is that there's a differential in terms of between 3 and 12 dB with the N95 masks filtering many more, having a greater filtration effect. And what we also know is that older adults are the most vulnerable to loss of auditory and visual cues. So people with hearing loss rely on visual cues to a greater extent than people who with normal hearing. And with hearing loss, because with hearing loss, we lose those high frequencies. And I'm going to present the enemy of many speech pathologists is this audiogram. And if you recall with the audio, this is your typical, this hearing loss is a little worse than what an older adult would experience, but most of your older adults, here you have your speech banana where most of the sounds of speech lie. Importantly, the consonants, as we know, are important for speech understanding. And what's happening is that the hearing makes it difficult to hear many of those sounds of speech, making speech inaudible. As nature would have it, those speech sounds, as we know, which are inaudible, are visible on the lips, so that people with hearing loss compensate by watching people when they speak. But of course, now we have the masking, which is a double whammy. So the impacts of reduced speech transmission are significant, and we know that speech reading is impacted as well. And a recent study by Trecker in an otolaryngology clinic in Italy verified this. And what they did is they looked at persons with hearing loss who were referred from the emergency department to the otolaryngology clinics in Italian hospitals. This was early on in the pandemic. As we recall, Italy was severely affected early on. So in their study, 13% of persons referred did not have any difficulties. So the majority of people referred to otolaryngology had communication difficulties. 25% presented with mild difficulties communicating, 37% with moderate, and about 23% with severe difficulties. And the main concern about face masks, of course, was the sound attenuation for 44% of the subjects, but the biggest problem was the difficulty in speech reading. So these individuals commented that hearing was impacted, but what really was problematic for the people with hearing loss was the difficulty speech reading. Speech quality degradation in combination with room noise and the absence of visual cues renders speech close to unintelligible for many of these people with hearing loss. And as I said before, older adults have the highest prevalence of hearing loss, and older adults, as we know, are the most at risk for COVID. So, and mortality from COVID. So this population is at great risk. So because of these, I mean, one of the, I think according to some researchers, the study that we did kind of stimulated interest in the different types of masks. And so this study early on by Corey was interesting. And at this point, we were able to have access to a number of different masks, including the face mask, the clear face masks. So what they did is they looked at the effects of different masks on sound levels and they looked at a variety of different masks. And most of us are thinking in terms of the clear face mask because of the visibility of speech sounds. So what their study revealed was a number of different, they confirmed our finding was that most masks have little effect below 1000 hertz, but attenuate higher frequencies by similar amounts to what we found. They found the surgical mask and the KN95 respirated had a peak into attenuation of about 4 dB. The N95 attenuated high frequencies by about 6 dBs. The cloth mask, as you'd expect, varied depending on the composition and the weave of the mask, but notably, the transparent mask performed poorly acoustically at the higher frequencies. So the transparent mask had the greatest impact in terms of filtration. And we know that a lot of people, especially with profound hearing loss, really need those transparent masks. And in their case, it's not a problem that there's this acoustic filtering, which we'll come back to. So the bottom line with their study is that tightly woven cotton and convex spandex blends should be avoided if speech understanding matters. The ubiquitous polypropylene masks offer the best acoustic performance among all masks tested, and the shape of the mask matters as well, how the tightness of the seal around the face. Shields and masks with windows perform worse acoustically than opaque cloth masks, and surgical masks are the least attenuating. So, bottom line from their study, persons with hearing loss perform significantly better when listening to and watching a speaker wearing a, well, no, so let me just go back a minute. So the bottom line from their study was that the transparent masks are significant in terms of the attenuation, but you would predict that in terms of speech reading, they're definitely going to be better. And Thibodeau, just hot off the press, just came out in print today. They did an interesting study looking at speech understanding with speech masks. And what they found was that persons with hearing loss perform significantly better when listening to and watching a speaker wearing a transparent mask over an opaque mask, which is not surprising, but it's important to have this data. Listeners, and interestingly, in terms of confidence, listeners felt more confident when listening to and watching a speaker without a mask than when listening to and watching a speaker wearing a transparent mask or an opaque mask. So these were people with all different types of hearing, different severities of hearing loss. Confidence is rated significantly higher for the transparent mask compared to the opaque mask condition, and listeners reported having to concentrate less when communicating and watching a speaker with a transparent mask. And fatigue and listener fatigue and concentration is very, very important, because when people are fatigued, when they're kind of trying to listen and communicate, oftentimes they tune out if there's too much fatigue. So that's going to be another contribution to mishearing. And again, this study is just hot off the press. It just came out in print this morning when I woke up. I mean, I had read it beforehand, but this just now out now. So now we're in healthcare settings, and you folks are working in healthcare settings. You folks are working with people, obviously, with dysphagia, and hearing is obviously one of the many problems that your patients will face. So what are the impacts in healthcare settings? Effective communication, as we know, is critical in healthcare settings. Adherence is very, very important. And I know that Dr. Ashwini commented on adherence with your patients with dysphagia. If you can't hear the instructions from the physicians or the healthcare providers, speech pathologists, it's hard to adhere. There are significant clinical impacts to effective communication. This was prior to COVID, we know about this. And some of the impacts, communication, as we know, is at the heart of delivery of healthcare. It's critical to the healthcare provider relationship. It's critical to developing trust with the speech pathologists and the physicians and the therapists. Understanding complex concepts is critical in healthcare settings, and treatment adherence, as we know. So communication is at the heart of healthcare delivery, and hearing is an important part of that feedback loop. So life as a patient before COVID, before COVID, people with hearing loss had difficulty providing information to clinicians and caregivers. They had difficulty understanding treatment options. They had difficulty following treatment recommendations. They had less participation in decision-making, and they rated their care less, they were less happy with their care in healthcare settings prior to COVID, higher hospital readmission rates for persons with hearing loss prior to COVID. And now we know, and now post-COVID, we have things very much exacerbated. Of course, again, we have difficulty providing information. Masks makes it difficult to interact with the healthcare providers. It's hard to understand, need to focus. If someone is going to operate, it would be good to see their face. Patients in the operating room don't get to even see the face of their surgeon, and difficulty understanding healthcare providers, from respiratory therapists to aides to speech pathologists. So again, the COVID is impacting healthcare delivery. And a recent study that just came out last week or the week before, looking at communication between surgeons and patients. And these Kratzky and colleagues looked at patient perceptions of surgeon communication, trust in surgeons, patient impressions of surgeons' masks, provision of clear and understandable instructions. And they conducted an RCT, but just to give you a feel for what it sounds like in the operating room.
Do you have any questions about that?
So that's the doctor talking, and the surgeon talking prior to the surgery that he was going to be performing on this patient with a cholesteatoma. So an RCT, these guys performed an RCT, and surgeons were randomized to wearing either standard covered masks or clear masks. So here you have your standard cloth mask or you have your clear mask. And there were 15 surgeons who participated, and there were 200 patients who participated in this study. And the outcomes I thought were kind of interesting. I'm not sure if they were surprising, but they were kind of interesting. The surgeons, 53% said they were unlikely to choose the clear mask over their standard covered mask. They lack confidence in the protection provided by clear masks. And I think we know that they're not as effective in terms of preventing spread of the virus. Patients, of course, preferred the clear mask to the standard mask. It improved surgeon communication and appreciation for visualization of the surgeon's face. Masks created verbal and nonverbal barriers, easier to hear the surgeon when wearing a clear mask, and able to visualize nonverbal visual cues. Those are some of the comments from the patients. And when surgeons wore a clear mask, the patients rated their surgeons higher for providing understandable explanations, demonstrated higher empathy levels, and better able to build trust. And the type of mask did not impact comfort level with surgeon doing operations. So whether it was a clear mask or a material mask, that didn't matter. So we know that in some hospital settings, sometimes clear masks are provided, especially to patients that have significant hearing loss, so they can communicate better with the physician or healthcare provider. So, and then there's a study, again, this was in 2021, that was published, impacts on communication experience. This was a study done in Manchester by Gabby Saunders and colleagues. And what they looked at was how individuals perceive the communication experience based on the need to wear face masks and social distancing. And this study was done at the time when the UK was on lockdown. And what Gabby Saunders and her colleagues found was that face coverings change the content of and perceptions about an interaction. And I think these have some clinical implications for speech pathologists and audiologists when communicating with patients. Communication became more about information sharing with little or no informal chat. These are the perceptions of the people, the respondents. Conversations tended to be shorter, flowed less well, they were less personal and engaging. Emotions and reactions were hard to read, according to individuals wearing masks. And these are not in hospital settings. This is a variety of different settings. At a cognitive level, participants reported need to use extra concentration and effort to communicate, and that they were more fatigued following communication with someone wearing a face mask. And that is going to affect the ability to understand, and the ability to remember, because at that point, people will tune out. So the Hearing Loss Association of America was interested in, and Cochlear Corporation, they were interested in looking at the effects of face masking on communication in persons with hearing loss. And so they surveyed and they found that 95% of people living with hearing loss in the US said the face masks impacted their communication. 68% of those with hearing loss said it increased their use of technology during the pandemic to communicate with others. And 87% of hearing healthcare providers said they had seen an increased signs of loneliness or isolation in their patients since the pandemic began. So
Barbara, yeah, very sorry to interrupt. We got about 5 minutes left. Does that sound good?
That's good. Yeah, that's good.
Okay, great. Thanks.
Thanks. So what we know is that hearing from the pandemic and based on the HLAA work, 70% of persons with hearing loss said they're more aware of the hearing loss due to pandemic. That could be a good thing for audiology and speech pathology. 47% said they're more eager to explore hearing loss solutions. That's a very good thing for some audiologists. But 46% that said that hearing loss influenced their mental health in terms of increasing anxiety, isolation, loneliness, confusion, and forgetfulness. And we know that Dr. Ashwini touched on isolation, anxiety, and depression in persons with dysphagia following discharge. And 52% said they feel less connected to family and friends as a result of their hearing loss during the pandemic. So solutions, there are a number of solutions. So I just wanted to offer some tips for communication. And these are things that you ordinarily would do with people before masking, but there's certain things that you can't do when people wear masks that you could do when they were not masked. You want to make sure the room is well lit and speak to the other person. Well, the well lit is really in terms of seeing the eyes, because the eyes are going to relay a lot of information, and also seeing body language. You want to make sure to speak clearly and slowly. Try to possibly use a more of a low pitch voice because that's less attenuated. Try to keep the sentences short. When you're starting a conversation, try to address the person by name so that they know that you're talking. Avoid changing topics or interrupting others. Shouting is not going to be helpful. And if a hearing aid is an option, is not an option. Use of assistive devices is very, very important. In terms of people with face masks, make sure that you turn down background noise. Make sure you communicate one person at a time. Confirm that your statement is understood. Teach back is helpful. It's helpful if there's a friend to help communicate, although people with hearing loss don't want others to communicate for them. They want to be spoken to directly. And for folks that have significant hearing loss, there's a lot of wonderful apps that are available, and these could be helpful for you when you're working with some of your dysphagia patients. Just some apps, and I could send you these if you're interested. There's speech to text apps, there's smartphone amplification, there's caption television. So there's a lot of different, and there's text to speech apps. So there are a lot of different apps on the phone that you can use to help individuals understand. And then we have many hearing aids have remote microphones. So the use of remote microphone stuck inside of a mask, for example, a clear window mask, can help. So if patients have hearing aids and have those remote microphones, those can be very helpful as well. So in closing, in terms of audiology, hearing loss may be a the COVID virus may be a disruptor in terms of the fact that many individuals with hearing loss and their loved ones are now realizing how important hearing is and connection is to our overall quality of life. While the pandemic has challenged our ability to hear and connect, this realization is empowering consumers to act and seek treatment for hearing loss. So in my view, perhaps one of the unintended consequences is maybe the stigma of hearing loss may be a little bit lessened. So in conclusion, mitigation strategies to minimize the spread of virus are essential. Mitigation strategies are, however, the enemy of persons with hearing loss. And let's use this opportunity to shine a light on the newly visible disability of hearing loss and disseminate solutions for members of the hearing impaired community. And thank you.
Wow, thank you, Dr. Weinstein. That was such an awesome and comprehensive presentation for 25 minutes. We really got a lot of informative and scientific knowledge in. We do have one question for you from Monica McHenry. She wants to know, in the surgeon study, the clear masks seem to fit poorly. Is that why the surgeons didn't feel protected? And if there are any versions of clear masks that fit better?
Yeah, so there's one clear mask that's FDA approved. Those were not the FDA approved. That was a good question. Those were not the FDA approved masks. But there is a clear mask, and if that person wants to email me, I can contact her with those. So there's one version of clear mask that's FDA approved that does provide the protection, but they're in short supply, especially at the beginning. It was impossible to get those clear masks. And we know that the clear masks are not as protective if they're not the FDA approved masks. So that could be one of the reasons.
Yeah, thank you. Yeah, I imagine there is a trade-off of fit, protection, and then the speech acoustics. We have a question from Dr. L Koenig, who is our next speaker. She says it's a technical question. She writes that putting a microphone inside a mask puts it in a moist environment. What kinds of microphones are suitable in that situation?
So I'm talking about the hearing aids that come with, many hearing aids come with a remote microphone, and we could just stick it into, so basically the person with the hearing aid can clip it into an area under the mask. And since the clear mask the shield, for example, is open, it's not going to be a problem in terms of moisture. The only thing but the clear mask, the remote mic, if it's used, you have to worry about infection. So if you can't just transfer it from one healthcare provider to another. But we have other, so that it could be a technical problem, but if you're using a face shield, that wouldn't be as much of a problem.
Thank you, Dr. Weinstein. There seems to be some interest in the clear masks and some of the other resources that you had in your slide. So if you want to share with us, we can share later with the attendees, or if you want to put any links in the chat during the next speaker, that would be welcomed.
Okay.
Thank you so much. That was excellent. Okay, and now I will introduce our final speaker for today, Dr. Laura L. Koenig. She is professor in the Department of Communication Sciences and Disorders at Adelphi University. She is a research scientist at Haskins Laboratories and also a research affiliate at the Leibniz Center for General Linguistics in Berlin, Germany. She is a linguist and a speech scientist with a prolific history of research. Her work focuses on understanding how speech production differs across individuals, for example, varying in age, sex, and native language. She's also looking at establishing relationships between the physiology of speech production and the resulting acoustic output. She's going to talk to us about research regarding speech through masks today. Dr. Koenig, are you ready to share your slides?
Yes, can you hear me okay?
Yes.
Okay, so just pulled up Monica McHenry in my database. Okay, is that good? Can you see that?
Yes, thank you.
Okay, good. So I'm very happy that Dr. Weinstein provided such a thorough review of recent literature because my talk doesn't do that at all. So I'm glad that that background has been established. And the scope of what I'm going to present here is that this is a study that I must say is the brainchild of Melissa Randazzo, and Ryan Prefer really did most of the legwork in terms of setting up the stimuli and the listening test. So very much a collaborative project. So I want to recognize my collaborators here. So thank you, organizers, for inviting me. And I want to just, I'm hoping with this talk that I can add one small additional dimension to what we've been thinking about here today. So we have been thinking about, in the recent talk, about the effects of face masks, particularly how they affect listeners. But I want to also point out with this talk that we want to think about the effects on speakers as well. Oops, sorry. So as we all know, face masks are effective in preventing the spread of COVID-19. But as we've also experienced and as we've learned through recent literature, they do have effects on the speech signal. They limit the acoustic transmission. They also limit visual information. I'm going to hide my little window here. It turns out that, as we have also been learning, masks not only differ in their efficacy at containing airborne particles that spread the COVID virus, but they can also differ in their effects on speech acoustics. And I'm ultimately going to suggest that they can also affect speech articulation as well. Oh, I'm stuck. There we go. So in other words, we can think of sort of trade-offs between mask efficacy in terms of virus transmission and communicative effects. And again, Dr. Weinstein has covered some of this literature more thoroughly than what I'm providing here. So the N95 masks are really superior in terms of protecting against virus transmission, but at least in some studies, they can attenuate sound quite a bit. So this 12 dB figure, I believe, matches what was in one of those previous slides. On the other hand, if we look at something like a simple cloth mask, depending on the nature of that cloth mask, they will offer less protection against the virus, but they may be superior in terms of their attenuating effects. So in some studies suggesting that maybe it's only 3 or 4 dB as far as how much they impact speech transmission. And I want to point out a methodological issue that arises in this context. So the Corey et al. Study was one of the ones that assessed many different mask types. And as one of their conditions, they effectively masks onto human-shaped dummies. And certainly a piece of what we need to understand is how different material types affect acoustic transmission, which will affect listeners and what they can recapture from the speech signal. But by sort of taking real speakers out of the equation here, there is a drawback in these studies in that we do not learn about how masks can affect speakers. That is to say, how masks can impact speech articulation. And just to underscore this, if we look at the reported effects of mask wearing, we see that there are reports, of course, of effects on listeners. So listeners report reduced intelligibility when listening to people wearing masks. And as we know, these effects are exacerbated for persons with hearing loss, older persons, persons who are second language speakers, all very important considerations for us. But masks affect speakers as well. So there have been studies in which speakers have self-reported that they perceive greater effort when speaking through a mask, that they feel they speak more loudly, they speak more slowly, they pause more. And as Dr. Weinstein mentioned, these can positively impact communication for the listener, but they may also have detrimental effects on speakers and their self-perceived efficacy. So in study, we undertook to assess the effects of 3 face masks, both on listener responses and the speech acoustics. We compared cloth masks, disposable masks, and the N95 mask. We looked at multiple speakers, 2 males, 2 females, and we specifically chose speech material that minimizes semantic predictability to get a better sense of exactly what is transmitted in terms of the phonetic information in these mask types. So we obtained recordings from professional voice users. They were all actors. Given you the technical details of our recording protocol. I'm not going to read this all for you, except just to say that these were fairly high quality recordings in terms of the equipment that we used. However, because of pandemic restrictions, we did not bring our speakers into the sound booth. We shipped the equipment to them and asked them to record themselves in their homes. And to try and find a space that would have limited background noise. And in their Manhattan apartments, they did that to varying degrees of success. So that is somewhat of a drawback to our methods, but was sort of unavoidable at the time. We had speakers produce semantically unpredictable sentences. So McHenry and I forget the second author, but this was a set of sentences designed so that they were mostly content words. They were all 7 words long, and you could not easily predict the end of the sentence from the beginning. So we processed these sentences to normalize them for amplitude. We mixed them with multi-talk or babble to simulate real world conditions, like that recording we heard of the operating room. And we, in each condition, speakers heard, in each condition, speakers heard different sentences. So I'm going to play you a couple of examples here. So this first one is the control condition, so no mask, but with the babble. So here's the original, in case you didn't get all of that. Here now is the N95 mask, again with babble.
Dr.
Yes?
I'm sorry to interrupt. The audio is not coming through. I'm not sure why.
You know what? Let me take off my headphones. Let me try it now.
Math instructors always allow pens before testing.
Does that work?
Yes, that worked. Thank you.
Okay, so my sound will be less good, but you can hear the clips. Okay. So again, that was the no mask condition with babble. Here's the original.
Math instructors always allow pens before testing.
Here is the N95 mask with babble.
They began mixing dangerous.
And again, the original.
They began mixing dangerous materials by beaches.
So as you can see, or as you can hear, a moderately difficult listening task.
Math instructors always allow pens before testing.
Sorry.
Math instructors always allow.
Okay, there we go. So our listeners, we recorded these folks through an online platform through Prolific. They did their testing online. We did have some exclusionary criteria. We lost some listeners. We can talk about that if you're interested. They all had to be native English speakers by self-report. They were all normally hearing based on their responses to the hearing handicap inventory. We told them about their mask use. Most of them did have quite a bit of experience both speaking through masks and listening to mask speakers. And each listener heard data from a single speaker in all 4 conditions. And we did this because we expected there might be individual differences in intelligibility. So here's our intelligibility data. So this is presenting just % words correct per condition. And I want to mention that intelligibility seems like a simple concept, but when you go about measuring it, it actually is kind of tricky. So that is something that, again, we could talk about if any of you are interested. So a rather simple measure right now, again, just % words correct. And what we find is the C1 here, this is the no mask condition, so about 80% intelligibility with that babble. All 3 mask types did reduce intelligibility. No significant differences in our data for the different mask types. Qualitatively, the effect was biggest for the N95. And one consideration that I'll toss out here, again, getting back to the way that we measured intelligibility. In our scoring procedure, a sort of near miss So it's exactly the same as a non-response. So if you substituted delicious for delicate, that would get the same kind of incorrect word score as if you simply did not report anything for that word. And we did note in going through the data that those non-responses were more common for the N95 mask. We did find speaker differences, which were significant. So in this study, our two men down here at the bottom were more intelligible than the women. So in the no mask condition, about 80% intelligible. The two women, intelligibility in the high 70s. For all four of the speakers, that N5, those black bars, were coming in as the least intelligible. So now to look at the acoustic effects of the mask. So for this, I just took the entire recording for each condition. So those 48 sentences, that whole recording, I just did a long-term average spectrum over all of those. And I'm showing you the results here for one speaker. So the blue here is showing the no mask condition. So this is intensity over frequencies up to 8,000. And what you see here is that all three of these mask types are reducing acoustic energy. But to look at this a little bit closer, we zoomed in on frequencies from 0 to 4,000 hertz to kind of pinpoint the frequencies that are most important for speech. And what I'm going to be showing you in the next slide is the difference between the no mask condition and the three mask conditions. Okay. So here, the black at the top, that is the N95 mask. So the fact that this is higher than the rest is indicating that that N95 is showing greater attenuation over a range of frequencies from about 700 hertz up to about maybe 2,900 hertz. And the cloth mask and the disposable mask are less, are showing less attenuation in those frequencies. So what struck me about this is that this particular frequency range is quite important for speech communication. So up around 700 to 1,000 hertz, that is in the region of a high first formant, which are the frequencies that we associate with lowered jaw positions. So for example, like an ah kind of vowel. And then these frequencies over here, 1,200 up to maybe 3,000, that's in the range of our second formant frequency, which carries a lot of important information on consonant place of articulation, also on the front-back vowel distinction. And incidentally, this is consistent with just spontaneous speaker comments on feeling constrained when they spoke through that N95 mask, which does have to be fitted to the face rather well. And this is brand new data. We did this for two speakers before. I've now got it for all four. All four of our speakers do show this pattern of higher attenuation over roughly that same frequency band. There is some variation in that. Speaker M1, who happened to be our most intelligible speaker, shows kind of an interesting little dip here at about 1,300 hertz. And I also want to mention here that these Y scales are different. So the magnitude is different for different speakers. A question that arises from this is whether these speaker-specific differences in the acoustic attenuation have anything to do with intelligibility differences, which is a really good question, and we're going to have to look into this. We don't have the data analyzed in a way yet that will show us that, but I certainly want to follow up on it. So just to sum things up here, even though we did not find significant differences among our masks in this study, there is some suggestion that the N95 masks are different. So again, in previous works, the suggestion that these do reduce acoustic transmission overall to a greater degree than their mask types. And additionally, they seem to be reducing particularly important frequencies for speech communication that we can understand in terms of a restriction on articulatory movement. So coming back to this notion of trade-offs, particularly if we are in a lower risk situation, if we are not necessarily in a healthcare setting with very at-risk populations, we might want to think about choosing our masks partly as a function of how well they will communicate the linguistic signal. Additionally, I want to underscore that there are speaker effects that we need to think about in mask wearing. We did see speaker differences in intelligibility, which is no surprise. There's a lot of work showing that speakers just naturally differ in their clarity. We saw this in the no mask condition. So just intrinsic differences in how clearly people speak. But at the same time, there seems to be possibly some speaker-specific responses to mask wearing. And that may in turn affect listener success in terms of how well they can understand masked speech. So the bottom line takeaway message here is that mask wearing certainly affects listeners, but it affects speakers as well. So again, I want to acknowledge my co-authors. I also want to acknowledge our speakers who volunteered their time. I also want to recognize the contributions of a number of research assistants supported by Adelphi University. And portions of this work were presented at the Virtual Acoustical Society meeting in December. We also published a version of that work in Proceedings of Meetings on Acoustics. So I will refer you to that work if you are interested in the citations. So, thank you.
Thank you, Dr. Koenig. That was an excellent presentation to finish off our COVID-19 on speech, swallowing, and listening. We do have a couple of questions, and they're kind of popping up in order. So I'm going to start first with Rachel Offram's question. She said, for audiologists conducting live voice testing for speech recognition, would your study then suggest that it is affecting the validity of the tests? And then if so, how should an audiologist account for it if they need to wear a mask when testing? It's a great question.
And I'm not sure I have a great answer. Let me turn on my video. So let's get back to the validity of testing how masks affect transmission without the human, but with the human. And my sense is that we just don't have a lot of data on how masks affect humans yet. I think it's just something that we need to look into more. Does it affect the validity of the tests? It certainly is a complicating factor. But as we know, there's two kinds of validity. There is the internal validity. So speaker effects can be a threat to internal validity, I think. But as far as external validity, of course, most of us have mouths and articulators, and we have to use them when we communicate. So for external validity, I think it's potentially a plus, if you like. Dr. Weinstein, please chime in here.
So that's really interesting. So I would say two things. I totally agree the external validity when doing speech word recognition testing with a mask will be generalizable in terms of real life. But I would suggest that we use taped speech. So you use, instead of you doing monitored live voice, we know that using tapes are reliable, much more reliable and much more valid. And clearly that's the way you should go in terms of, if you don't want to be impacted by if you don't want the internal validity to be impacted by speech testing. I would do it both ways, actually.
Thank you. So we had one more question, just if they were single or double masked. So our speakers in the study were single masked, but as soon as the recommendation came out to double mask, I was like, oh, we need to add a condition. There's always going to be a new condition to add as the situation is unfolding. Any other questions? From Dr. McHenry, one slide suggested that the speaker's response to mask wearing was increased vocal effort, which should improve articulatory precision. Do you believe this potential beneficial impact was counteracted by perceived restriction of movement?
So, increased vocal effort is an interesting one. This was self-reported, what listeners were aware of in how they were communicating through masks. And it's hard to know whether they were responding to increased respiratory drive, just trying to get louder, increased vocal fold impact frequency, which you would expect from greater driving pressure. When people think of increased vocal effort in clinical situations, that there is this notion that when people speak at greater effort, that it will increase speech clarity. I will say that I've done some work with a colleague of mine where we just looked at the effects of loud speech in typical speakers. And it's not necessarily the case in typical folks that at least speaking more loudly expands the articulatory space, okay? In certain kinds of clinical training protocols, that can certainly happen, but I don't think it's necessary. So, but the perceived restriction on movement is, yeah, it could totally be a counteracting effect on how much they increase clarity when they try and increase their effort.
Oh, Dr. Weinstein, you're muted.
Okay, so I wanted to just add to what Laura just said as well. So, and that's why in one of my slides, in terms of suggestions for how to communicate, you don't want to scream, because that increased vocal effort is not going to make your voice clear. It's not going to increase clarity. It's not going to improve understanding at all. So that jives with what Laura said. And I just want to also add that, we talk about in healthcare settings, we talk about how the masks affect the patient, but we should talk about the fact that we have many healthcare providers that have difficulty understanding because of hearing loss or just because of the masks, and we have to be concerned of that bi-directional communication. So oftentimes the healthcare providers are going to misunderstand what the patients are saying. So that's like an extra layer of problem.
And an additional source of stress for those healthcare providers if they are speaking more effortfully.
Yeah, that's true. Another thing that, also occurred to us was that the masks are standard sizes and faces are not standard in size. And so there might be a wear and a fit effect as well to explore later on. Any other questions or comments? Any questions for any of the three speakers? We're in the last few minutes of the event, so it's just open Q&A. Feel free to raise a digital hand. Okay, we're adding in the chat right now, Ryan Prefer's added our website where you can get more information about the events. We list our upcoming talks there and links to our previous talks, also the link to our YouTube channel. And Max Freeman has also posted in the chat the links for the CEUs. So if you are a clinician looking for ASHA CEUs, please fill in this form and you'll be contacted regarding the CEUs for the event. Okay, I think that's a wrap on NYC DCS number 3. Thank you to our speakers. We know that this is a really busy and difficult time in a lot of workplaces, so we really appreciate you coming and sharing your work with our community and being part of this event that is going to really help us have more of a research discourse within the New York State community of clinicians and scientists. So thank you so much. I'm looking forward to seeing you at the next one.